I'm Anil D'Cruz. I'm a surgeon and professor at the Tata Memorial Hospital, Mumbai. I'm also the director of the hospital. Tobacco use is rampant in our country, and one of the commonest cancers caused by indiscriminate use of tobacco is head and neck cancers. Head and neck cancers is truly the Indian cancer. About 1 in 3 Indian males will get a head and neck cancer, and it is the third most common cancer among women if you take out the breast and the cervical cancers, which is number 1 and 2. This is in contrast to the West, where head and neck cancers constitute only 4 to 5% of cancers. Now you might ask me, why is there such a stark difference? It predominantly has to do with the way we consume tobacco in our country. The tobacco we consume is chewed, it's smoked, it's inhaled in the form of snuff. Majority of the effects or the harmful effects of tobacco are locally, and they occur in the upper aerodigestive tract, of which the head and neck is the main area. Absolutely. 90% of head and neck cancers are tobacco related and absolutely preventable. So if we do not have tobacco in our country, you would not have 90% of head and neck cancers. I must add that the betel nut, or the areca nut to be technically correct, or the supari as we call it, is also carcinogenic. So it is not that you only have to have tobacco. So a widespread use time and again of the areca nut is also carcinogenic and can predispose to head and neck cancers. So the main challenge is our patients presenting late in the course of disease. 60 to 80% of patients present with locally advanced disease. Now you don't have to be a rocket scientist when I say this, but early stage disease is treated with a single modality therapy, either surgery or radiotherapy. The moment you have advanced disease, you need multi-modality therapy, surgery, radiotherapy, chemotherapy in various permutations and combinations. Now it's very logical that a patient presents with advanced disease, needs multimodality therapy. It has devastating effects on function and cosmesis, because the head and neck is very important cosmetically. It's in exposed areas of the body, and the most important functions of speech, swallowing and breathing are through the head and neck. So the moment you factor all these three treatments into that, it has devastating effects on our patients. Not only that, it also compromises survival. So we have 90% cure rates in first stage, it drops dramatically to 30 to 50% in stage 3 and 4. So the challenge of getting our patients earlier is probably the biggest challenge that we face. Basically, at the Tata Memorial Hospital, we drive what is known as two things. One is evidence-based practice. So the entire practice that we do is based on evidence. It is not that I am a senior doctor, I believe in a certain form of therapy and we'd advocate that to our patients. It has to be based on good, solid scientific evidence. The other differentiator that we have in Tata Memorial Hospital is we have a multidisciplinary tumor board before we decide on any treatment. In the private sector, time and again what happens is, I'm a surgeon, I'll push the patient towards surgery. I'm a radiation oncologist, I'll push the patient towards my specialty. I need to drive volumes. No disrespect to anybody, I'm just giving you a broad concept. But I think a number of private hospitals have also started the concept of a tumor board, and that's the way that we need to move and go forward. So generally in the tumor board, you have a patient, you have the surgeon, you have the radiation oncologist, and you have the medical oncologist. So the three major treatment specialties are present at a tumor board. So the patient's case is presented to this board, pros and cons are discussed, and then the right treatment is prescribed to the patient. We sometimes do have the radiologist and the pathologist involved as well. because we may want to review the histopathology slides. There are variations in different types of cancers. You may have the radiologist who will have a final look at the imaging and tell us that yes, the cartilage is involved, radiotherapy may not be better. The moment we have all the information from the specialist, we then turn attention to the patient. No two patients will get the same treatment in a select situation, and in that case the patient's general performance status, affordability, where the patient stays, how far from a specialized center, can they stay out in Mumbai for 3 months, that also decides on the patient treatment. 100% we would factor the patient and the relative into the final treatment decision. Pros and cons are described or discussed with them, informed consent is done, and then we would give the patient treatment. So that's a very how should I say, a very voluminous question. But if I have to say prevention, as I said, no tobacco. 90% of cancers will not be there. 90% of head and neck cancers, 50% of all cancers in our country would not be there. Government are doing a lot of legislations. We don't allow smoking in public places. Gutka and chewed forms of tobacco consumption are banned in the majority of our country. So we do have legislations, and current global adult tobacco survey shows that there is about a 6% drop in tobacco consumption in our country, which is very heartening. The second thing that we need to do is early detection. We need to make people aware of cancer, not only head and neck but cancer in general. Head and neck cancer is not an integral part of curriculum in MBBS and in the majority of post-graduations unless you do a cancer specific post-graduation. I think with cancer increasing globally a lot in our country, we need to make people aware. We did a little study when I was younger, and then again we repeated it in 2012. About 1/4 of patients come late because of the ignorance of the treating physician that they have seen. They're treating them for tuberculosis, treating them for non-specific ulcers in the mouth. They're not aware that it's cancer. Yes, patient-related factors also contribute, but I think it's a failure of the healthcare system if a doctor doesn't diagnose cancer. The patient has gone to the doctor refers to a specialist late. Not very correct. So we need to have emphasis on prevention and early diagnosis. Like I said, when they are through training, some part of cancer should be an integral part of the medical curriculum. When you're doing a MBBS, it should be part of that. And then regular updates. We must emphasize regular updates. If I've cleared my medical school in the 70s and 80s, and there's absolutely no pressure on me to update my knowledge, then it's obvious I'll only update my knowledge on areas that I'm interested in and not in other things. So we must have regular CMEs, credit points, validate our degrees so that our doctors stay up to date with changing trends in medicine, not only in cancer, but in other trends as well. So one of the huge things that has happened in cancer is the introduction of the robot. The robot is not so used in head and neck cancers. We do use it for oropharyngeal cancers. Widely used for oropharyngeal cancers in the West, because in the West they are seeing a new form of oropharyngeal cancers. It is cancers that is caused by the human papilloma virus. But really, if you ask me what are the innovations that we have done at the Tata Hospital, it's towards more functional surgery and surgery that rehabilitates our patients very well. So when I was a trainee, we would reconstruct defects in the head and neck using flaps which were not microvascular based flaps. Today, if I have to resect someone's jaw, I have microvascular reconstructive methods available to me. I'm able to harvest bone from the patient's leg, put that bone in place of his jawbone, later give implants with teeth on that, getting my patient back to near total functional and cosmetic rehabilitation. We also rehabilitate our patients in who we remove the voice box. We now have speech buttons We have various forms of innovations that we can use the remnant larynx to fashion a speaking tube so that our patients can maintain communication. As in our country, speech is one of the most important forms of communication, where a large majority of our brothers are illiterate. So that's another innovation that we do. When we treat tumors in the nose and what we call the paranasal sinuses, which is adjacent to the nose, we now use endoscopy. So we go in through the nose, we are able to take out a large majority of these tumors that way. So we don't do open surgery in that area anymore. So they are innovations, but as I said, if you ask me to sum it in two words, towards better function and cosmetic preservation.